Okay. You'll let me know when this is gone and we can get started. But thank you very much for the invitation.
Yes, sir. It's our pleasure, sir. You are in our virtually with us.
Yes, I am. Yes, I am.
Kuntal, start.
At first, Abhishek will start. Abhishek, please start.
Yes, sir. Okay. Good evening, everybody. Myself, Abhishek Chakraborty, Faculty of English, Department of Humanities, Midnapore City College, West Bengal, India. Today is a great day for us as we have gathered here in this virtual platform to attend the international webinar on current trends in neuroimmune pharmacology organized by Department of Biological Sciences and Paramedical and Allied Health Science, Midnapore City College. We need to remember that our world is being haunted by COVID-19 pandemic. People are now afraid, but we are making sure that the fear will never be able to control us. Medical personnel, scientists, researchers, scholars from all over the world are trying their best day and night to give us a moment of solid win against the pandemic. Amidst this, we have to spread hope, positivity, and awareness, not the virus itself. Knowledge and information are the only ways to achieve that edge against COVID-19. This webinar aims to serve that purpose. In this regard, I am honored to welcome Dr. Howard A. Gendelman, Margaret R. Larson, Professor of Internal Medicine and Infectious Diseases, Professor and Chair, Department of Pharmacology and Experimental Neuroscience Center for Neurodegenerative Diseases, University of Nebraska Medical Center, USA. It's a proud moment for us to have him with us today. I would also like to welcome Dr. Pradeep Ghosh, Honorable Director, Midnapore City College, and Dr. Sudipta Chakraborty, Principal, Midnapore City College, for their gracious presence with us. Now, on behalf of Dr. Pradeep Ghosh, Honorable Director, Midnapore City College, I am requesting Dr. Kuntal Ghosh, Assistant Professor, Department of Microbiology, to share some of his valuable thoughts with us regarding our college and this very webinar.
Thank you, Abhishek. Good evening to all. On behalf of Honorable Director, Midnapore City College, I welcome all of you to the international webinar on current trends in neuroimmune pharmacology, organized by Department of Biological Science and Department of Paramedical and Allied Health Science, Midnapore City College, West Bengal, India. I am feeling very proud to say that our college is operating in the international field of academics and researches. We not only have proven ourselves in these fields, but also have achieved the national and state college ranking, 41st in India and 7th in the state of West Bengal. But we are not satisfied by it, as we are striving for the more. I hope that in future days our college will do more to enrich the world of the global academics. Today I am glad and delighted to welcome Dr. Howard E. Kendall MRL Professor of Internal Medicine and Infectious Diseases, Professor and Chair, Department of Pharmacology and Experimental Neuroscience Center for Neurodegenerative Diseases, University of Nebraska Medical Center, Omaha. We have this eminent scholar and a researcher with us today, and it's a very proud moment for us. Finally, I am concluding my speech wishing an enriching session. Thank you.
Thank you very much, sir. Now we must continue our webinar. In that context, I would like to request Dr. Sudipta Chakraborty, Principal, Midnapore City College, to welcome our honored guest and start this webinar.
Thank you, Abhishek, for this opportunity. And I am introducing Professor Howard E. Gendelman, Margaret R. Larson Professor of Internal Medicine and Infectious Diseases, Professor and Chair of Department of Pharmacology and Experimental Neurosciences, Center for Neurodegenerative Diseases, and he is the Editor-in-Chief of a renowned journal, Neuroimmune Pharmacology, and co-founder of Exavirtherapeutics of University of Nebraska Medical Center, Omaha, USA. It is my great pleasure for introducing Professor Dr. Gendelman. He is, for the past 40 years, he has studied the mechanism of viral persistence, suppression, and elimination. more than 580 peer-reviewed publication, an H-index of about 109, and 38 patents are credited to this work that built his laboratories and his research centers, then an internationally renowned department of University of Nebraska. And what was achieved at the studies of the neuroinfectious and neurodegenerative diseases, PAT, the foundation of the translational research that supports the current research speech. And within the past decade, he played a principal role in the generation, testing, and development of long-term, slow effective release of the antiretroviral drug delivery, immune transformation as a viable therapy of Parkinson's, Alzheimer's disease, CRISPR-Cas9 viral gene expression for HIV/AIDS cure. I'm requesting to Professor Gendelman to start his presentation, and will prosper. I am expecting will prosper by his presentation. Thank you, sir. Sir, you can start.
Okay. Well, certainly it's an honor and a privilege to join you today. I realize it's late in the afternoon and evening, and hope we'll be able to engage not only during my lecture but afterwards with any questions you might have. This is a relatively new format. The last year or so, it's blossomed as a result of not such a good outcome, which is COVID, that's affected all of us in a very significant manner. My lecture today will be on immune transformation in the brain, and it's an area that we have pioneered in the strongest of manners over the past 20 years, and most recently has led to back-to-back clinical trials that were quite successful. We'll report them today within the next hour. Also, I must say that the next generation of neuroimmune pharmacology centers around in significant measure on the work that we were doing or are doing with Moderna. Moderna had developed the mRNA delivery that many of you know for the COVID vaccines. We are now using this delivery scheme to repair the brain using delivery or nanotechnology to bring key immunomodulatory cytokines to the brain in areas of injury, and that's what we'll talk about today. I do believe that the mRNA platform, not simply for vaccines, but for treating a number of autoimmune and degenerative diseases, will have a very brilliant future in the time ahead. Now, what I must be able to do, I hope, is not only transform the science, but transform my computer screen so I can present it to the group. So I'm going to push this button. I hope it's the right button, and it'll give me my screen. Okay. Hold on. Okay. Okay, I will need the organizers of this Zoom conference to let me be the main presenter, to transfer that authority, so I can put up my screen to the audience. Might you allow me to have that capability?
Yes, Professor. He's just now trying now. Just wait a bit.
Okay. We can wait maybe a minute or two.
Yes, yes, yes.
If there are any questions so far, I didn't talk yet, but maybe people have some questions in reading our prior work. I'll be happy to answer while we're waiting for the screen to be changed and the lecture to begin. Okay, since there are no questions, at least right now, I'm sure there will be soon, I will give you a little background of our work in the meantime, so we can use our time as wisely as possible. This research really stemmed from the idea that all elements of the immune system can modulate brain function and neurobiology. So what do we mean? Over the last 30 years, it became very clear that inflammation, mainly induced by microglial activation, was a principal driver of neurodegenerative diseases. But we didn't know at that point in time whether it was a cause or an effect of the disease. We now know that it can be both. And during the process of development of misfolded, aggregated, and nitrosylated proteins, in the case of Parkinson's disease, alpha.
Excuse me, sir.
Yes.
If you click in present now option, you can get the screen and then you will present this one.
Okay.
A window, you open your slides at first, then
I did. My slide sets are open. Yes. Help me through this. My slide sets are open.
a window, then you choose a window, this arrow option, you have to click this arrow option, third one arrow option.
It says entire screen. I'll do that. Is that the option?
Not the entire screen. A window.
It says it still can't share the screen. Okay. Let me try this again. I am okay. So you'll have to tell me. It says it can't share the screen, but you'll need to tell me. It says a window.
A window.
Okay, so I push that.
Yeah. Then you can get your slide. You can see you have opened, sir.
Yes. Let's see. Now it's working.
Yeah. You
Now
click
it's not working. Okay, let me try again. Okay. So there's two prompts here. I'm sorry, we'll lose a little bit of time, but we'll get it. It says your entire screen or a window. Which one do we push?
a window, sir.
Okay, so I push a window. Then it says select window or screen.
Presentation. Select presentation.
Okay, it does not give me that option. It says meet CQF or entire screen. Those are the two options I'm given.
Or entire screen, sir.
Okay. And then it goes below, it says allow or block.
Allow.
Okay. And then the prompt comes on, it says you cannot share your screen. Go to system preferences for more help.
Sir,
okay.
If you
What?
send presentation to me, our technical person can share it. If you have not any problem, you can.
Okay, it's not working. Email me with your email address, and I'll do that right now.
Yes, sir. My email address I am sending.
Okay, great.
Secretary secretary at Moraine at gmail.com. Sir, you got it? The mail? Secretary? Hello? Hello, Dr. Gendelman.
We are having some technical difficulties, so kindly cooperate.
Professor Gendelman joined. Sumon, please share the professor's screen. You got it, Sumon? Sumon, you got it? Sumon, you got it, the mail? Suman, I have sent you. Already I have sent you. Suman, just you present it. Dr. Gendelman, hello. Is not here probably. Professor Gendelman, I have already sent a confirmation mail. If you send me the PowerPoint file raw, I will share the presentation, sir. Hello?
Professor Gendelman probably muted,
Sir,
actually.
you unmute, please. Sir, please you unmute, sir. Sir, it is muted.
Okay, can you hear me now? Can you hear me?
Yeah, I'm here. We hear you. Actually, the box file, there have a registration option, sir. I have registered, and I am seeing here we have sent you a confirmation email. I didn't
Okay.
get confirmation. Box sign up, verify email.
Okay. I'll let the students start at in 5 minutes. My time would be 7:30. I guess it's around 12. What is the time? What is the time now in your university?
5:55 actually. It is not the problem. You can, sir. Sir, I saw the all files, but it is not open actually. Sir, if you send the raw PowerPoint file to me by mail, I will present, sir. That's not the problem.
Yeah, the files. The problem. Hold on for 1 second. Let me get my my IT people to help me. But I think what we can do, the easiest way to do it, because is I've sent you a PDF. Look at the previous email and see if you can pull up my PDF file I just sent you by email. The PowerPoint's too large, so
Yes,
but the PDF should arrive.
sir, I am presenting here.
Okay, great.
Okay, sir. No problem, sir. I will.
Okay, we have it. Oh, great! It looks like you got it.
Okay, sir.
Very nice. Very nice.
Tell me next. I will change this slide. That's not.
Okay, perfect.
Okay, sir. Thank you.
Okay.
Equally present, sir. No problem.
Okay. Okay. First of all, thank you for your patience. I duly apologize for the delay. I think we're all learning how to best communicate through changing times. Otherwise, I would certainly have traveled to be with you in person. So maybe next year we can make all that happen. So really what we're going to talk about today is immune transformation, not necessarily immune pharmacology, but how we can transform the immune system for therapeutic gain. Next slide. You're going to have to move the slides for me because I can't do that.
Yes,
on
sir.
my end.
You can start, sir. No problem.
Yeah.
Tell me next. I will.
Next. I'll just say word next. Next.
Yes, sir. I'll change.
Okay, so the science of Parkinson's that we're going to talk about today is the notion that both arms of the immune system, both the innate, principally the microglia, and the adaptive, or principally the lymphocyte, play a role in changing the homeostatic environment of the brain. So this notion, this idea, has really given rise to what we believe to be an effector response. For a long time, many years, it was thought that inflammation or immunity was a result of ongoing degeneration of neurons and neural dysfunction. But we now believe that the opposite is true, that the adaptive immune system, along with the innate microglial inflammation, plays a causative role in affecting neuronal function and neuronal vitality. Next. So we know that these diseases are very common. As you can see, many different people, very famous people throughout the world, have been affected by neurodegenerative disease, and specifically Parkinson's disease, as we go on. So these are international importance as we seek. This doesn't know any location, any person, any political ideology. It does globally affect many world populations. Next slide. Next. We know now from what we have in therapy that the world population is aging. The therapies that are available specifically for Parkinson's disease are symptomatic. They're ameliorative. So we have replacement L-DOPA therapy or dopamine agonist. We can do deep brain stimulation to affect tremors and movement and agility, but these all together are not affecting the disease course. They only target the symptoms. So our work in neuroimmune pharmacology and the overarching goal of our research is to halt or potentially regenerate the damage by using transformative immunotherapy to combat brain degeneration. Next. So let's start from the beginning and make sure that we're all together with the common terminologies that we're going to develop. Parkinson's disease, like Alzheimer's, is a long-term disorder of the nervous system, but in Parkinson's, the effect is on the motor symptoms. Like all neurodegenerative diseases, the symptoms come slowly over time and are progressive. The symptomatic part of the disease is shaking, rigidity, movement disorders, difficulty walking, difficulty getting out of a chair position, and evolving to cognitive and behavioral problems that occur in later stage of the disease. Dementia is a common component, but depression and anxiety are an allied component. And more than a third of patients throughout this course of neurodegeneration and Parkinson's have these types of syndromes, or not one facet, but multifaceted signs and symptoms of this disease. Next. So clinically, we talk about tremor, rigidity, disturbances in movement, but there's also autonomic effects of Parkinson's, pain and sensory disturbances, mood, sleep impairment, and progressing also to dementia. But the Lewy body disease, or the accumulation of intraneuronal inclusions, does also affect the autonomic nervous system, right? So the heart, the bladder, the symptoms and the signs outside the brain become a major part of the disease progression. Next. So what do we know about the pathogenesis? What do we know what causes the disease? Well, there's a lot we still don't know, but mechanistically, the dysfunction of proteasome, the accumulation of alpha-synuclein aggregates and nitrosylation of proteins, both in glial cells and in neuronal cells, the disturbances of autophagy, mitochondrial dysfunction, and cellular apoptosis, and inflammation is what we'll talk about today, the neuroimmune pharmacology of Parkinson's disease, which ultimately cascades with genetic influences, intracellular destruction of pathways and subcellular organelles, specifically the mitochondria, and induction of autophagy leading to cell death. And all of this is superimposed with aging. Next. So what's the disease? What do we know about the final processes of this disease state? Well, if you look at a simple hematoxylin and eosin stain of the area most dysfunctional in Parkinson's disease, in a normal brain, there are tyrosine hydroxylase neurons. These are dopaminergic neurons in the substantia nigra pars compacta. And specifically, over the course of these impairments, these neurons are destroyed, and they're selectively destroyed over time. And as the destruction occurs, the symptoms get worse. The compensation is impaired, and the agility, the movement, the coordination, the gait disturbances become the major signs and symptoms of what we call Parkinsonism or Parkinson's disease. Next. But we can look at this by PET or SPEC. In this case, MRI and inclusions. And what you see ultimately are signs and symptoms of inflammation surrounding areas of the brain or adjacent areas in the map. And this is an MPTP map, but this is also present and operative in humans. I'm using an MPTP as a model, a preclinical model of Parkinson's disease, and one can see a clear association between inflammation and degeneration. Next slide. Next. So what do we know about this process? Is Dr. Gendelman just telling you a story? Or is there real evidence that immunity and PD and Parkinson's disease are interrelated? Next. So for the past 20 years in our work, we really have pioneered a simple but important concept. And I want to pause and just take a moment and go over this concept, because this concept is not limited to Parkinson's disease or Alzheimer's disease. It's fundamental to relationships of injury and immunity. So the idea when we call stop in regulatory cells, one is in the midst of injury. What happens in injury? What happens in injury is that neutrophils and ultimately macrophages, monocyte macrophages, are recruiting through chemokines and cytokine signals to the area that is affected either by a microbial pathogen or a degenerative process or by injury. The innate immune system then elicits phagocytosis and clearance and intracellular killing. But during the course of activation, whatever the insult, that dendritic cell or that mononuclear phagocyte presents an antigen. And that antigen then elicits a cytotoxic T cell response, or a helper T cell response, or a B cell response that generates antibodies or direct killing of that pathogen or that injurious process. But if that is allowed to continue unabated, the disease would get worse, because the effector cell not only will destroy or eliminate the pathogen or the inciting size of injury, but it will continue, it will accelerate the disease. So there has to be a break. And that break is the second arm of the innate in the adaptive immune system, or that interface between innate and adaptive immunity, beyond antigen presentation and mobilization. And that stops that ongoing clearance mechanism, and that's called a regulatory T cell. Now, we got heavily involved in the regulatory T cell. Next. We got heavily involved in that regulatory T cell because we found that these inclusions, these alpha-synuclein, predominant alpha-synuclein inclusions, these intraneuronal bodies that we saw in postmortem examination and are part of the disease process, can break immunological tolerance. So the misfolded and changing form is presented by the antigen presenting cell as if it was foreign. And that elicits the effector response. And that's why we've seen, and others have seen, a tremendous increase in effector cytotoxic T cells early in the course of disease. Why do we see this? We saw this because this alpha-synuclein aggregate, this nitrosylated protein that's inside a neuron, will ultimately break immunological tolerance. Next slide. Next. So what happens as a consequence is activation of microglia, the production of neurotoxins, increased oxidative stress. But that's what we've known for 40 years or more. The bottom part of that is new because it's not simply the role of the dendritic cell or the microglia, but the activation of the adaptive response below left of my slide that talks about T cell recognition to alpha-synuclein or nitrosylated alpha-synuclein, generating a Th17 or Th1 effector response that comes into these inflammatory regions that are adjacent to the neuronal destruction in the pars compacta, the substantia nigra, and ultimately accelerates the neuronal injury that occurs. Okay, I'm going to pause for a moment and make sure that everyone who's listening understands that fundamental concept that I reviewed over the last 15 minutes, because we're going to build upon them on the pharmacology bent. And I want to make sure that if there's questions, I can address them and that everyone understands the fundamental concepts here. Are there any questions? Okay, either everyone's a super duper smart, or it's late in the day. I don't know, but this is certainly a complicated project. But we're going to move on. I'm going to assume that everybody gets it and understands the basic fundamental building blocks, and we're going to move forward. Next. So when we talk about CNS immune activation, the idea that we can see this in a pathological specimen is true. So look at the upper right-hand corner. You can see an activated microglia. On the bottom right-hand panel, you can see infiltrating T cells. So there's that interplay between innate and adaptive immunity with egress of CD4 positive and CD8 positive T cells, the production of autoantibodies, the higher levels of HLA-DR expression in the microglia, and the inability of these activated microglia to clear the pathogen, these aggregated released alpha-synuclein aggregates that are nitrosylated that form the basis of both innate and adaptive immunity, are insufficiently cleared in the setting of Parkinson's disease, and a big part of disease progression. Next. And we know that there is a relationship between the alpha-synuclein and neuroinflammation. How do we know this? Because we've been able to subtype by transcriptomics, RNA-seq, and metabolomics, and proteomics. There's a number of new technologies that are available that we can look and pinpoint these inflammatory foci during the course of progression of Parkinson's disease. Next slide. Next. So these ideas, next. Oh, I'm sorry. Back up 2 slides. Previous. Okay, stop. Stop here for a moment. So we, meaning my own group, have been active in this research for more than 20 years. More than 20 years. But it's always lonely. It's lonely if you're the only one pursuing this line of work. And the interest can only grow through collaborative cooperation and affirmative research. So a recent work of the last couple years came out from the group at Johns Hopkins, or groups at Johns Hopkins and the Columbia University, that also had shown that T cells from patients with Parkinson's will recognize alpha-synuclein. And that really gave a further foundation for this important work. Next slide. So this really puts it all together. What we're trying to say here is all contained in this slide. So let's take a moment and look at it, review it, and build upon it. But the idea that dead neurons or aggregated proteins of alpha-synuclein or infectious agents can by themselves activate a microglia. Once the microglia is activated, they'll secrete a plethora of pro-inflammatory signals. Things related to oxidative stress, icosanoid products, the COX-2 pathway, INOS, pro-inflammatory cytokines. And those signals in the face of oxidative reactive species will affect neuronal vitality and viability through altering protein adducts and structural damage, lipid peroxidation, DNA adducts, induction of the NF-kappa B pathway, and ultimately a cascade of events that will lead in the conjunction with advancing age and environmental toxins in the right genetic milieu, neuronal destruction, and then a feedback mechanism to inducing more microglial activation, presentation of antigen through this altered alpha-synuclein, and mobilization of effector T cell responses. Next. But we had to study it. The problem with any type of biomedical research is you need a viable animal model. We have now several of these viable animal models, the beginnings of which was an MPTP neurotoxin, but now we have made adenoviral inducing alpha-synuclein, and we can aggregate alpha-synuclein in vivo in the exact areas that are affected in human disease. We've been able to do those things, those processes, but the MPTP remains the gold standard to rapidly induce neurodegeneration in the exact areas affected in Parkinson's disease to give us a biological anchor. Next slide. And the MPTP itself, intoxication, next slide, can get through and penetrate the blood-brain barrier. Within the astrocyte is the MAO affecting and through or conversion of MMP plus to affect the electron transport stage within these areas of the substantia nigra and inhibit the complex and alter ATP synthesis and eventually induce neuronal dysfunction and ultimate neuronal degeneration in the same areas affected by Parkinson's disease. Next slide. Next. So when one looks at what happens vis-a-vis MPTP, you can compare it to the PBS. The train of events is very reflective of what happens in human disease, but it occurs faster. We can induce an acute Parkinsonism, and it allows us to study this phenomenon quite well. The MPTP induces reactive microglia. The reactive microglia within days specifically destroys the neurons, the dopaminergic neurons in the substantia nigra, and affects its connectivity, leading to altered survival of the terminal connections in the striatum. So all the pathological features, both inflammation and neurodegeneration, are mimicked in this model system. Next. So how do we put the pieces together? How do we put these pieces together? And what are we saying about the interrelationships between wound healing and Parkinson's? So essentially our model really is a recapitulation of how wound healing occurs. You get a scrape or a cut. This is actually a true picture of my 6-year-old grandchild who skid, fell down the steps, ended up with an abrasion, and then within days, the abrasion healed. How does that occur? Well, it occurs because neutrophils are brought in, macrophages are brought in, there's a healing response or containment and intracellular killing of the debris that occurred from the injury. T cells are then brought in to accelerate the healing process, and then the alteration from the effector T cell to the regulatory T cell leads to a healing process. So we reasoned that if it works well on a peripheral wound or a cut or a scrape or a local infection, why can't we mobilize these same type of responses to cure or alter or slow the progression of Parkinson's disease? Makes sense, right? Simple. The best science, we all believe, is the simplest science. Next. So this is what we've done in a cartoon. We've induced a transformation between effector and regulatory T cells. We've mobilized effector signals, so those regulatory T cells will enter the brain. They'll induce an anti-inflammatory response to control the microglia, and at the same time, accelerate wound healing by preventing oxidative stress, reducing neurotoxicity, and affecting the astrocyte response, or the innate astrocyte response, to release growth factors ultimately affecting neuronal regeneration or neuronal protection. Okay, next. So we started our work through using Copaxone. It's a simple piece. It has been used in multiple sclerosis. It can induce T cells that will be a Th2 or regulatory phenotype. It produces IL-4, IL-10, IL-6, and TGF-beta. These are all regulatory cytokines. And we felt, as a proof of concept, let's look at what transformation can do in terms of neuronal protection in the setting of a Parkinson's model. Next. And that's exactly what we saw. When you look at this schematic slide, you can see the inflammation on the top, that's MAC1. In the middle, it's this SN, it's this substantia nigra, a tyrosine hydroxylates that follows the inflammation. And you can see on the left-hand side that there is an inflammatory response, as I showed you before, and within a week, the neurons are killed by MPTP, about half the neurons survive. But if we adoptively transfer lymphocytes that are stimulated by Copaxone, we can reverse the neuronal degeneration. We can induce the striatal connections as normal. And when we use other antigens like ovalbumin, this process goes away. And if we deplete the T cells, the process goes away. So we had our early evidence that we can induce a induction, or we can affect induction of helper and regulatory T cells. And that induction will speed neuronal protection. This is the essence of our neuroimmune pharmacology paradigm. Next slide. And we saw this not only pathologically, this is by histology. We used MRI to look at this is N-acetyl aspartate, which is a marker of neuronal vitality. Next slide. One can see that in MPTP, this is yellow, we're killing the neurons. We're going from yellow to purple. But if we use Copaxone or adoptively transfer lymphocytes that are stimulated by Copaxone, you can see the regeneration, which is typified in a colorimetric change from purple to yellow. Next slide. Next. Next. And this is a dose response as we transfer by intravenous inoculation more of these regulatory cells. There's a greater level of neuroprotection. So there is kind of a relationship between the numbers of these Th2 or regulatory cells and the degree of neuroprotection. Next. And that's related, as I said before, it's not only the regulatory anti-inflammatory response, but the induction of the astrocyte growth factors that help this regenerative pathway. Next. So what about adaptive immunity, and specifically adaptive immunity and neuroinflammation in Parkinson's disease? Next. Well, we know that the nitrosylated alpha-synuclein induces a microglial superoxide and inflammatory response. But we came to learn in our own recent work and affirmed by our colleagues at Columbia University that nitrosylated alpha-synuclein will activate T cells as well. And so we wanted to study that T cell response. Next. But if our theory was right, if we immunize with nitrosylated alpha-synuclein, we should induce effector responses, like I showed you or told you, and that effector response should make the neuroinflammation and dopaminergic neurodegeneration worse. And that's exactly what happens. You can see in the fluorojade experiment on the left, and the right is the tyrosine hydroxylase neuronal response. But if you see the nitrosylated in the middle lower panel, that MPTP that's given in conjunction with nitrosylated immunization, the alpha-synuclein induction, we can see that the entire substantia nigra pars compacta is gone, is absolutely gone. So we can demonstrate, and we have demonstrated for the first time, that immunization with nitrosylated alpha-synuclein will induce an effective response and will kill neurons. Now we have evidence that both the innate and the adaptive immunity are operative, causing neuronal destruction. Next. But we had to show that we can transform this response. And the only way we can show that is not simply taking an aggregate of T cells that were done. We had to dissect the various T cell responses, the Th1 and the Th17 response. And what we show here is that both the Th1, when we isolate the Th17, the Th1, and the Th2, we can show that the Th1 and Th17 are bad. They're accelerating neurodegeneration, and they're reducing more of these neurons. But if we look at the Th2, they're protecting. So this yin and yang between regulatory and effector T cells are very important for neuroprotection and neurodegeneration. And now we've shown it directly. Next. So we moved to Nebraska. That's where I live. You guys live in a different part of the world. Actually, when I first moved to Nebraska, I moved because people said it was the good life. It was quiet, simple, very supportive. And I thought, even though the university was still growing and developing, we can make a lot of progress in a relatively short period of time. So I made that move. Next. And that's exactly what happened. And not only did we make all these observations, but what's very exciting is that other groups now around the world, in Europe and in Asia, and obviously in America, that people were getting the same data, that we were able, or other people were able to reproduce our results. So I always say that affirmation is the best compliment. If other people are able to reproduce your work and they're publishing it in better journals, that's even better. That's even better. It's always frustrating when other people repeat your work and then they say they're the first to do it, but we have to deal with that. Luckily, the publications are timed, and it's all clear who was first and who was second in making this observation. Next slide. Next. So we go back to the neuroprotective T cells, and we've affirmed it by other people. Next. But then we had to find for sure what T cell was responsible, exactly responsible for the neuroprotection. We believed that it was a Th2 or a Th3 or a regulatory T cell, but at that point we had no direct evidence. We knew that IgG1 and IgG2 were upregulated, their regulatory T cell involvements, obviously, but we had to prove it. Next. And we did. We were able to generate naturally occurring regulatory T cells. There are a bunch of pharmaceutical agents. We won't have time to go into that, but we can, in fact, induce a, what do we say, a putative regulatory T cell by our own drug treatment, by histone acetylase inhibitors, vasoactive intestinal peptides, vitamin D3, B venom, or granulocyte macrophage colony stimulating factor. But pharmaceutically, we should be able, in addition to Copaxone, which is a more broad agent, we should be able to go specifically after the regulatory T cell population. And that's exactly what we did. Next slide. Next. What we did here is generate regulatory T cells and then pull them out of the spleen and the lymph nodes, and then adoptively transfer in low-dose MPTP-treated animals and see if we can prevent the disease, accelerate improvement, and reverse neurodegeneration. That was our question. And we took out the effector cells that we believe were bad, the regulatory cells that we believe were good, and they serve the basis of this yin and yang. Next. And that's exactly what we saw. If we adoptively transfer these cells into a low-dose MPTP inoculated mouse, we showed that the regulatory T cells in the right-hand corner of the panel, the histology, the graphics are in the left. And if we do the same number of effector cells, we'll call TEF, you can see the level of inflammation by the brown staining of the microglia is very different between the TREG and the TEF. One's being much more significant and severe, and one's is much more attenuated. Next. And that correlates with neurodegeneration. You can see the TEF MPTP, there's very diminished levels. And the TREG MPTP, the neurons have been regenerated, and we can quantitate all that by stereology, and the data was in fact correlative, including the staining of the striatum, the connecting termini, very different than the MPTP or the MPTP plus TEF, which is the effector cells. So there clearly is that yin and yang in the upper panels between the MPTP TREG and the MPTP TEF in terms of the numbers of viable neurons in the dopaminergic axis versus the vitality of the striatal connections. Next. But the interesting part of this, and this is probably something that happens once in 20 years or 10 years, you get a result that you're incredibly excited about, that may make the difference in a field. Now, we're still early in this, obviously, and our clinical trials are just beginning. We finished 2 of them. We have a big phase 2, phase 3 coming to build on this concept. But I must say, for the students in the audience, that I've been in science for a long time, probably longer than most of you have been alive, 41 years. And we publish a lot of papers. You said that in the beginning. We all publish a lot of papers. But the papers are not, the numbers of papers aren't important. What is important is the ability to take those observations and transform those observations into something that will benefit personkind, will benefit people suffering from these diseases. And when we saw this result, we were super excited. Now, what this result says in the upper right-hand corner, which says it all, is if you look at the PBS and you look at the MPTP and the effector cell, the experiment here was transformation. So, and I'm going to spend some time talking about this, and I know I'm running out of time, so we may have to stop halfway through, and maybe you'll invite me back to go through the clinical arm of this. But the most important result is those last 2 panels on the right-hand side. So we were able to show that these effector cells are accelerating the destruction of these nerve cells and making Parkinson's disease so much worse. All the neurons are out, all the connections are out, and the animals have difficulty ambulating and have a progressive form of Parkinson's disease. But we believe, because the immune system is placid, we believe that we can transform the effector cells into neuroprotective regulatory cells by pharmacological means. I just told you, we have vasoactive intestinal peptide, we have granulocyte macrophage, colony stimulating factor, we have HDACs, that we have a number of drugs that we know that can induce a regulatory T cell response. But we did not know if they can take something bad that was induced by alpha-synuclein or MPTP and transform that into something good. Well, if true, that could present an unbelievable opportunity for clinical investigation and clinical improvement. This is exactly what we saw. Not only can effector cells destroy the neurons, but if you look at the upper right-hand panel in that brown blob and the striatum, we've been successfully able to transform these cells. And that transformation leads to complete neuroprotection. If you look at the left-hand panel, the PBS, which is phosphate buffered saline, and you look at the right, which is the transformed T cells, they're virtually indistinguishable one from the other. This was one of the most exciting findings of a single experiment that I was involved in the last 40 years. Next. And again, going back to what I showed you earlier, that treatment reduced the inflammation. This is an MRI scan, and you can see those red dots compared to the earlier fragments of what we saw previously. We've been able to reduce the inflammation and decrease the neuro destruction and elicit neuroprotection by this strategy. Next slide. So the hypothesis is that brain inflammation and neurodegeneration can be attenuated by regulatory T cell transformation, and that deficits in TREG and TEF frequency and function do occur in Parkinson's disease, and immune aberrations in the periphery may serve in the pathobiology of what we see during human disease advancement. And that ratio represents not only important biomarkers, but therapeutic targets that can produce and elicit disease outcomes, improve disease outcomes. Okay, so the second half of my talk is about a critical part, and I'll just summarize it because there's another 40 slides, and unfortunately, we started a little late, so you're going to have to invite me back in 6 months or whatever, and to do another Zoom conference. But the beauty of making that observation is we were able then to move this from mice to humans. And we now are testing 20 patients that we can transform the effector to regulatory T cells. We've seen in our recent reports some very, very exciting outcomes of our patients that got better. We're now in the throes of doing a phase 2 study to prove definitively that this therapy will work and make people better, and at the same time develop reasonable and supportive biomarkers for disease progression. Okay, I'm going to have to stop at 8:10, and I'll be able to open this up for questions. I always feel there has to be time for questions. And again, I will more than agree to come back if you like to hear the clinical component of this lecture in the months ahead. I'll be happy to come back and lecture once again. Okay, so questions?
Questions, please. Audience. Questions to Professor Gendelman.
Okay, I hope I didn't put everybody to sleep. Is everybody asleep? Nobody's asleep. I hope. So some of my students, they hear me talk so much that they start snoring. They start falling asleep during my lectures. But
they're impressed, sir. They're very impressed to your work.
Actually, Professor, the YouTube live session is also going on here, and most of them are really enjoying this session. So they have not asked any question yet. So we just told, I think they will post some questions now.
okay, let's wait a few minutes.
No, it's okay. You can carry on, sir. After the end of the session, I will, if they post anything, I will tell you.
Oh, okay. Well, this is the end of my talk, so.
Okay.
There's a second half is the clinical arm, but that will take another hour, and we'll have to reschedule that. This was the time that I could allot, at this particular point. So we'll have to, this is all the basic science that led to the clinical part. And the clinical part is also very exciting because we've been able to reproduce all of this in humans, which makes it very, very exciting, and make people better, which makes it even more exciting. But I'll stop, or I need to stop, and then field any questions that may have. If there are no questions, I'll certainly come back and we'll present the clinical arm in the next lecture that I'll give.
Sir, sir, we have some couple of questions, sir. Anivesh Mondol, he is asking that can targeting the oligomer could be a way of the therapy of Parkinson?
No, that's fine. The problem with targeting the oligomer is that more oligomers will be made. So there'll be more proliferation of the inciting neurotoxic factor. You have to transform the disease. You can't just stop. That's why I think all the Alzheimer's therapies, and some of which are being used, have never been terribly effective in people, because they targeted one aspect of the disease, which is the oligomers, and the oligomers continue to accumulate even with the monoclonal antibodies. So I think, in my mind, that immune transformation is much more promising. But we'll see. Again, the definitive clinical trial, which is 240 patients, has not yet started. So we'll have to know in about a year and a half, what actually has happened. But I believe, this is my belief, not anybody else's belief, that you have to transform the immune system at the same time that you clear the oligomers. Very good question, by the way. Excellent question.
Okay. Another one question is there, sir. How does the inhibitors like HDSCI and the vitamin 3 help in the T regulatory cell?
Well, I think these are adjunctive therapies. I think they can help, and I think they can be important. Because this is a multimodal disease targeting multiple aspects of the pathobiology, and certainly we believe we're getting at the heart of it by immune transformation, but we're not the only game. And using multiple conversions and multiple promising therapies are going to be more likely to be successful than doing one alone. So I agree with that.
And that's the end of the questions, sir, actually. And most of the participants, they are really thankful. They just post in the YouTube live session. They are very much thankful, and they said they have enriched their knowledge in the field of the Parkinson diseases.
Oh, great. Well, thank you so much. I am offering my services again in whatever, 6 months or a year, whatever you think, or even earlier, for the second half, if there's interest in that. And we'll love to continue our relationships. We have positions available in America in this program. And if any student or postdoc is interested in experiences in this area in the US, please write me, and I'd be happy to respond accordingly. Okay, thank you so much. And again, I apologize for the delay. It's my fault, and I guess we're all learning about the computer systems.
No, it's okay, sir. Now, Dr. Savoni Bodhan will deliver the vote of thanks.
Okay, good evening, everyone. I am here to present the vote of thanks for today's webinar. I would like to thank our speaker, Professor Howard E. Gendelman, M.R. Larson Professor of Internal Medicine and Infectious Diseases, Professor and Chair, Department of Pharmacology and Experimental Neuroscience, Center for Neurodegenerative Diseases, for visiting and enlightening us with his knowledge. Today's webinar was full of knowledge and interesting things. I gave deep insights into the topic and also revealed some interesting facts. The point where Professor Gendelman told us about the insight of Parkinson's diseases and its treatment was really informative to us. I am pretty sure the precious knowledge that Professor Gendelman gave will definitely help us in our studies in future. Once again, I would like to thank Professor Gendelman for taking out time from his busy schedule and enlightening us with this knowledge. Thank you so much, sir. I would also like to thank Honorable Director, sir, Professor Dr. Pradeep Ghosh, for giving permission and encouragement to organize this webinar session. I am also thankful to Dr. Sudipto Chakraborty, Principal of Midnapore City College, for inviting Professor Gendelman to conduct it. I want to thank all of the participants to make this event successful. Also, thank you to Mr. Suman Mallik for technical support to conduct this webinar smoothly. I would end my speech here. Thank you. Thank you, all of you.
Thank you, ma'am.
Okay.
Thank you, Professor Gendelman. Thank you.
Now, thank you.